Hi everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. My email is 3klpm@gmail.com. I am also the medical author of the two books Focused Neurology and Exam Oriented Clinical Neurology. We are continuing with the series of lectures of Prime Neurology. There are 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, one would have acquired a good knowledge of neurology. Right now we are on part 26 Prime Neurology, Sleep Disorders, part 2, Types of Sleep Disorders. So in this episode we are going to discuss the types of sleep disorders. Sleep disorders. Disorders of sleep are among the most common problems seen by clinicians. Patients may complain of difficulty in initiating and maintaining sleep at night, that is insomnia, excessive daytime sleepiness or tiredness, unusual behaviors during sleep, that is parasomnias, and circadian rhythm sleep disorders. Insomnia treatment. Primary insomnia is a diagnosis of exclusion. Treatment of a medical or a psychiatric disease that may be contributing should be addressed first. Attention should be paid to improving sleep hygiene and avoiding counterproductive behaviors before bedtime. Cognitive behavioral therapy emphasizes understanding the nature of normal sleep, the circadian rhythm, the use of light therapy, and the visual imagery to block unwanted thought intrusions. The treatment of insomnia. Pharmacotherapy is reserved for instances when insomnia persists after treatment of contributing factors. To understand treatment, we need to understand a particular concept. Acetylcholine, histamine, and orexin. These three substances increases wakefulness. Acetylcholine, histamine, and orexin are the hormones or chemical substances which are responsible for promoting wakefulness. And when we give treatment which antagonizes these substances, that is orexin, acetylcholine, that is anticholinergic drugs, antagonizing antihistamine, person gets drowsiness. So when we antagonize orexin, patient becomes drowsy. The classic example is narcolepsy, where there is deficiency or absence of orexin. If we give anticholinergic drugs like amitriptyline, it antagonizes cholinergic levels and again patients becomes drowsy. The drug chlorpheniramine maleate, which antagonizes histamine, which is a wakefulness promoting hormone, so person becomes drowsy. So the side effects of orexin antagonist, anticholinergic and antihistamine is drowsiness, because they antagonize orexin, histamine, anticholinergic and acetylcholine, which are wakefulness promoting substances. So after having understood this concept, now it becomes easy to understand the treatment of insomnia. So pharmacotherapy is reserved for instances when insomnia persists after treatment of contributing factors. Antihistamines are the primary active ingredient in most over-the-counter sleep aids. Benzodiazepine receptor agonists are effective and well tolerated. Options include Zaliflon 5 to 20 milligrams, Zolpidem 5 to 10 milligrams, Triazolam 0.125 to 0.25 milligrams, Isopiclone 1 to 3 milligrams, and Temazepam 15 to 30 milligrams. Heterocyclic antidepressants such as Trazodone 25 to 100 milligrams are often used due to their lack of abusive potential and lower cost. Limit use to a short period of time for acute insomnia or intermittent use for chronic insomnia. All sedatives increase the risk of falls and confusion in the elderly, and therefore if required, These medications should be used at the lowest effective dose. Evaluation of a patient with excessive daytime sleepiness. So, what are the findings on history and physical examination we should note? The diagnostic evaluation, the diagnosis, and finally the therapy. Findings on history and physical examination. If they have difficulty waking in the morning, rebound sleep on weekends, and vacations with improvement in sleepiness. Sleep log is the diagnostic evaluation. The diagnosis is insufficient sleep. The therapy would be sleep education and behavioral modification to increase the amount of sleep. Suppose on findings of history and physical examination we notice obesity, snoring or hypertension, we need to assess by polysomnogram, and the diagnosis would be obstructive sleep apnea. The therapy would be continuous positive airway pressure, upper airway surgery, dental appliance and weight loss. On history and examination, if we find cataplexy, hypnagogic hallucinations, sleep paralysis, we do a diagnostic evaluation on polysomnography and multiple sleep latency test. As I said in the previous episode, generally it takes 1 hour to 1.5 hours for the NREM stage to complete and enter into REM. But in narcolepsy, where there is an absence of orexin, which is a wakefulness promoting hormone, they quickly go into a sleep stage and they quickly enter into the REM. So once they quickly enter into the REM, the sleep latency test when we do, and then we notice that they quickly enter into the REM. REM is a stage where dreams occur. So they'll have hallucinations, hypnagogic hallucinations, hypnopompic hallucinations. REM is the stage where they have atonia. So they have sleep paralysis, cataplexy, loss of tone. When they become emotional, or when someone cracks joke, when they laugh excessively, they fall down because there's loss of tone. In REM stage, there is loss of tone. So since they enter into the REM stage quickly, they have loss of tone, and with emotional trigger, they fall down quickly because of loss of tone. Why is there loss of tone in REM state? Because dreams occur in REM state. So not to enact our dreams, nature has given a wonderful protection of developing atonia during REM sleep. So they enter into the REM sleep quickly, which we can diagnose by multiple sleep latency test, where they enter into the REM stage quickly. So the diagnosis would be narcolepsy. The therapy would be stimulants like modafinil and methylphenidate. And since they enter into the REM sleep quickly, we have to suppress the REM sleep by giving REM sleep suppressing antidepressants like venlafaxine and sodium oxybate. On history and physical findings, we notice restless legs, kicking movements during sleeps. The diagnostic evaluation would be assessment for proper medical conditions, example iron deficiency anemia or renal failure. The diagnosis would be restless leg syndromes with or without periodic limb movements, and dopaminergic therapy is very useful for restless leg syndromes. So the therapy would be treatment of predisposing condition and if possible dopamine agonist like pramipexole and ropinirole. And on history and physical findings, we find sedating medications, stimulant withdrawal, head trauma, systemic inflammation, Parkinson's disease and other neurodegenerative disorders, hypothyroidism, encephalopathy. We need to do a thorough medical history and examination, including detailed neurologic examination. The diagnosis would be sleepiness due to a drug or medical conditions. The therapy would be obviously change medications, treat underlying condition, consider stimulants. Circadian rhythm sleep disorders. Insomnia or hypersomnia may occur in disorders of sleep timing rather than sleep generation. So insomnia, that is lack of sleep, or hypersomnia, excessive sleep, may occur in disorders of sleep timing rather than sleep generation. Such conditions may be organic due to defect in the circadian rhythm, pacemaker, that is hypothalamus, or environmental due to disruption of exposure to entraining stimuli, light dark cycle. Examples of the latter include jet lag disorder and shift work. Shift work sleepiness can be treated with modafinil 200 milligrams or armodafinil 150 milligrams taken 30 to 60 minutes before the start of each night shift, as well as properly timed exposure to bright light. Safety programs should promote education about sleep and increase awareness of hazards associated with night work. So these are the exciting concepts of disorders of sleep. The other important concepts of clinical neurology I have put in a book called Exam Oriented Clinical Neurology, written by me, Dr.Sreenivas, published by White Army. This book contains all the essential elements of clinical neurology, and this book would be very useful for students appearing for clinical neurology exams. If interested, this book could be purchased. The other book I have written is Focused Neurology. This contains all the essential elements of neurology, put it in a question and answer form. This book will be very useful for students preparing for oral exams or viva. This book is written by me, Dr. S. Sreenivas, published by CBS Publishers and Distributors. This book is available online from all leading booksellers including Amazon. So if interested, this book could be purchased online. As I said earlier, there are 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, one would have acquired a good knowledge of neurology. We are just now done with another episode of Prime Neurology on sleep disorders. I hope you have enjoyed listening to these wonderful concepts of sleep disorders. If you have enjoyed it, please like, share and subscribe to my YouTube channel, Dr. Sreenivas Medical Concepts, which is India's leading neurology educational YouTube channel, and my web page, Dr. Sreenivas Concepts. Thank you. Bye.